My name is Oscar Lovelace. I am here today to talk about my 25 years of experience as a rural family physician, and the State Office of Rural Health has asked me to discuss issues regarding office security and safety. I've been in practice here in Prosperity as a rural practitioner since 1988, almost 25 years, and I have to say that security and safety issues are not that common, but when they do occur, we have particular ways to handle that. The first thing is we have a code word that we will page overhead if it's a safety issue regarding an unruly patient or someone who feels threatened. We'll say code white, and that alerts the physician and the office manager in the practice to come to the front. If we say code red, then we're concerned about a fire. We do not have an automatic button up front to call the police, but we have let our front desk know if they ever feel physically threatened by violent behavior that anyone in the office is very much encouraged to call law enforcement and have them arrive. Thankfully, we're in a little small town close to the police department, so it wouldn't take them long to get here. When a person comes to our office asking for drugs, the most common situation would be they would be asking for a refill of a narcotic because they might be dependent on that narcotic. And we typically try to handle that with our nurse triage personnel. We have someone dedicated to basically handle all the phone calls and patient clinical concerns that occur when we're working. If they come in and say, I need a refill on a medication, and they are prescribed that medication and do the refill, then we give them the refill. However, if they were to come in and be seeking a refill beforehand, or they were seeking just to get a medication, say they came in off the street and said they just need medicines, we would tell them that we do not have any controlled substances in our office, and they would need to go to the emergency room if they felt that they were in that much distress. We would then alert the ER that this person was coming, and also allow them to have any information we have about whether we feel that they're a substance abuser. On a very rare occasion, someone might show up in our office under the influence of alcohol or some other substance like marijuana. Those would be the most common. In that particular case, if the person was violent or unruly, we would resort to Dr. White again and have the physician and the office manager come up front and make sure that we had police here as soon as possible. That actually has never happened in our practice. But otherwise, we would try to usher that person into our treatment room and then sort of assess the situation. If we thought they were of harm to themselves, and we would, look at it from a medical standpoint. If we thought they were more likely to be disruptive, then we might get law enforcement involved to have them removed from our practice. The issue of securing drugs in the practice came up, I would guess in the very first year that I was in practice, and we decided early on that the best thing to do was not to have any scheduled drugs in the office, because then if someone is a drug seeker, they know that they're not going to be able to get any scheduled drugs like morphine or Demerol or any kind of injectable here from us, or even, for that matter, scheduled drugs that what someone would take orally. So by telling people that we do not have any scheduled drugs in the office, and it's well known then in the community after being here 25 years, we don't have people seeking in our practice, I think it's probably best to leave that to the local emergency room, because we have very good medicines now like Toradol that can control pain when someone comes in with a kidney stone or has a need for acute pain relief. Obviously in medicine, people frequently are under great duress, either because of health problems or personal, family, social problems. And when those situations arise, we do our best to try to put that person in an area in our office, or put that clinical situation, even a situation that might turn into that kind of a problem. We try to put that person in our treatment room and alert the nurse, or the nurse alerts. I guess what I'd say, the front desk would first alert the nurse, and the nurse would then alert the physician. They have a situation that might potentially be volatile. And in that case, we have even put the police department on notice that we have a situation that could result in a problem, and they might be on site, like be in the parking lot, if we're aware that we've got to break some news that's going to be very distressing to a patient or a family member. So I think first and foremost, being sure the communication lines are in place and making sure that you go ahead and alert those that might be needed early on. The second thing is that it's probably best to involve the clinician in that early, because they usually have the longest relationship with the patient or the most significant relationship with the patient or the family member, and can sort of pace the situation. By allowing someone to be calm, meaning if someone is using a rapid pace of conversation, you slow down your conversation. If someone is using a high-pitched, a lot of stress in their voice, you lower your tone and give a more soothing voice. It really does work. And of course, in some occasions, we might even use an injectable like Benadryl or a medicine that would calm a person, short of getting, scheduled drugs in a situation like that. I guess that what I've learned is sometimes if you're aware that there's going to be a volatile situation, instead of allowing everyone to be in the room at the same time, it helps to sort of break up the group before you might consider bringing them all together. So let's say, for example, a mother entered the office and her teenage daughter was there, and there was a need to report how her daughter was doing because the teen was a minor. But you're trying to respect the privacy of the teen by keeping the teen and the mother separate initially and making sure that the mother understands everything that's going on before the two of them were together in the same room. I think is a smart idea. In a situation where we were actually involved in violent behavior, and that hasn't happened in our office, it's happened in the hospital where someone physically attacked one of our staff members. The most important thing is for someone to make a call immediately to the police department and have them arrive on the scene as soon as possible. We would physically restrain that person from hitting someone else, but we would not strike first, I guess is what I would say. And we would work more toward restraint, physical restraint, and certainly not to be assaulting someone. The concern comes up sometimes about a patient who has mental health problems, and when we see these patients in the office, we really treat them like we do any other patient. If we see that they're particularly upset, we try to alert the nurse, then alert the physician, get the patient in the room, and have them calm down first, using pacing techniques and conversation and that sort of thing. On a rare occasion, we might give someone an injectable of something to calm them down, like Benadryl, if we felt like that was necessary. But I would say more commonly we would run into a patient who was psychotic and they might be trying to take their clothes off in the practice. We've had that happen a few times, or exposing themselves. And in that case, it's just better to remove the person from the lobby or the waiting room and have them go into the treatment room where we could start the process towards stabilization. And usually with conversation, that person can be managed, especially when that person is being seen by their usual nurse or their usual nurse practitioner or physician in the office. We try on an annual basis to review safety issues. For example, we have the equivalent of a fire drill where we review the techniques for getting out of the building safely and what our codes are for distress, the Dr. White, Dr. Red, or Code White, Code Red. I would say that we probably should do it more frequently. Probably once a quarter would be a good thing, but at least we try to do it when we're going through some of our accreditation and continuing education regarding OSHA requirements. So if you can remember to at least do it when you're talking about needle safety and things like that and extend it over to this safety and security of your office, it's a good idea. One of the concerns we have at work is the fact that we don't work 8 to 5. People get here as early as 6 o'clock in the morning, and last night I was here till way after dark. And we may come in the middle of the night to get some information that we need about a patient, or actually to pick up some samples for someone. So what we do is we allow all of our employees to have access to the building, but we tell them that we're concerned for their safety. We ask them to always leave out of an entrance that is well lighted, and if they have any concern about safety, if they see someone in the parking lot and they don't feel comfortable walking out to their car by themselves, they can call the police department and have them, the local police department will come and escort them from the building. We've had that happen on a few occasions where there was some suspicious behavior in the parking lot, and the police officers have been very willing to be here. And they patrol our parking lot on a regular basis because we're a busy place. Because all of our exam rooms have a phone and an intercom, it's very easy for any of our staff, if they felt threatened, or if they were a woman and they felt like they were being put upon in some inappropriate manner, they could easily push the intercom button and a page would go out across the building to alert someone that they need some assistance in this room. And all of our rooms have a code name. It's not hard to know where someone is, because we'll say, please come to L2, and staff will arrive at L2. We have an office full of people, so it'd be sort of inconceivable that anyone would be more than about 20 or 30 feet from another human being when they're in the office. I think talking about safety and security issues in the office, probably the most important thing is to be sure that you are communicating with the staff, and the staff feels that they can safely and securely communicate with you. Because one of the issues that comes up is if you have a sort of a drill sergeant mentality in your office, people may not share with you their concerns, and if they don't share with you the concern, then you could have something really unfortunate happen, that if you had just been apprised of it earlier, a plan to address the problem could have been developed before it ever happened, or possibly even prevent it from ever reaching the point that it became a crisis.